Thank you all for inviting me to speak, and I feel like I have a bit of a dubious honor here to be the non-anesthesiologist speaker, but I'm sharing that with a surgeon, so at least I can pass the baton. I don't have any relevant disclosures to this topic, but I do perform CT and MRI, chiefly of the aorta, and then a bit of vascular ultrasound. So in the course of this talk, I'll cover an unknown case and then cover the indications and the appropriate uses of CT and MRI for acute aortic dissection. We'll cover all the different elements of what you should expect from an appropriate report and talk about some special considerations such as pregnancy, renal insufficiency, or if you have to repeat an exam, and then we'll give you the follow-up of the unknown case. So this is a real page I got a couple years ago, an after hours page, and Dr. Taylor works with Dr. Petak now. He's at Maryland these days, but he's an emergency radiologist, and I anonymized the slide, of course, but he called me, and I just happened to be at work, so I walked down to the ED, and he had a really good question, and I thought it was perfect for this talk, this case. So it's a 40-year-old female. She's G2P0, so she's 18 weeks pregnant, trying again, and she's a very high-functioning engineer, very aware of medical diagnoses, and was transferred from another teaching hospital after that afternoon. She presented with acute chest pain and hypertension. An echocardiogram was performed, transthoracic, and it showed severe eccentric aortic insufficiency, and they questioned an aortic dissection flap. And just because of availability of cardiothoracic surgery coverage, she was sent to us. And so here's that outside echo. And so it was a difficult exam. She's a little tachycardic. The left ventricle was a little dilated. I think I'm seeing 5.6 there in the LVID. The aortic arch didn't show a clear dissection flap, but there was a little bit of a question on the back wall of the aorta here. Maybe saw a flap, and then something that looked like it. We weren't really sure, and pretty significant aortic insufficiency. This is a new diagnosis for her. She was not known to have any cardiac disease. So it kind of brought up the question that Dr. Petak and the whole team asked me, which is, what's the appropriate next step? So you could consider doing a repeat transthoracic echocardiogram, a transesophageal echocardiogram. I think we might need to zoom the slides out a bit to see all the entire content, please. If we wanted to take her to the OR and consider doing a TE in the OR, would we go to a CTA? No, she's pregnant, so there's some considerations with radiation there. MRI, MRA, invasive angiography has been posited as a way to work up aortic dissection, or just go right to a CT surgery consult or cardiology consult. So I don't know what you would do if at your institution, and the local practice may vary. I can tell you what we did. And that's that we did a couple of these things at once. So since she was transferred, even though we had the outside images, we did repeat a transthoracic echocardiogram, because that's what cardiology fellows do when they're consulted. And we also consulted surgery, because she'd already been shipped here, and we know that time is of the essence. So before we talk about the very next step, I thought I'd review some literature. And so here's a meta-analysis from Archives of Internal Medicine, and so it's 20 studies. Basically, the conclusion of this meta-analysis was that all three, transesophageal echocardiogram, helical CT, and MRI, at least in the 2006 era, were all pretty much equivalent. They all had very high sensitivities and high specificities, and so they all perform in that top left corner of the ROC curve. Now, the authors go on to mention the choices that might practically be made, so they conclude that really all three are equally reliable for diagnostic values, but that a clinician must take into account the availability of each imaging test at their institution, because time delays can add to mortality, right? There might be a wide variety of expertise at any given practice site, and I think that persists even more than 10 years later. If there's a clinically strong suspicion, that don't accept an initial negative test, regardless of which one you choose. More recent guidelines, this one from the American College of Radiology, kind of affirm that. And so here in this guideline, we rate based on it's kind of 1 to 10 appropriateness. And so everybody should get a chest radiograph. It's pretty innocuous and can tell a lot. But CTA comes out on top, just edging out MRA, with note that scanner availability, local expertise, and time to diagnosis matter. And a transesophageal echo is equivalent to an MRA. in that regard. But MRA without contrast, a little lower. Aortography is kind of fallen out of favor. And ultrasound transthoracic, and though we've done it here because that's how we got into this place in the first place, in this case, it's not considered a sufficient workup to exclude dissection. So we'll leave our case to be continued, and I'll kind of go through some more information. So we all know the aortic anatomy, and it's very important, especially when we're looking at potential type A dissections, to see the sinotubular junction well and look closely at the ascending aorta, and they tend to move a lot. So it's important to note that cardiac CT and cardiac MR have a far inferior temporal resolution to ultrasound. So if you're trying to see these structures, you might have to apply ECG gating or run the scanner at its fastest temporal resolution. You can do that, of course, and freeze the motion. This is an ECG-gated long axis view of the LVOT and the aortic root, and you can see that you can actually see coronary arteries just fine. You can see the sinotubular junction very well, the aortic valve. So it's certainly possible. That requires a little extra expertise, and one thing you might start with is just a non-contrast portion of the scan, just scanning the chest and axial views, and that's actually something that you could probably even do on your PACS, even if you don't have a full report yet. You can see these as they're coming off the scanner pretty much. If you're going to measure the aorta, you want to go at the level of the right pulmonary artery, and you want to use this plane. If you're using axial images only, that's the only legitimate plane you can measure an aorta, but you could look for enlargement as a predisposing risk factor, and of course, the non-contrast has some very important diagnostic features. I believe it's imperative, and it's always an option. No matter where you work, as long as the patient's stable enough to get them to the scanner, which has to be a consideration. You can at least do a non-contrast scan, no matter how bad the kidneys or the IV axis is. This is an intramural hematoma here, and so you can see that without any difficulty, and that's dense material in between the walls of the aorta. I also find the